about 77% reported that the possibility of preserving their fertility was instrumental to coping both before and after treatment. And that's something that we are seeing clinically as well. And so I want to share just a little bit of a local experience of what we have. So the first is an email that I received from a patient's mother back in July of 2020, who emailed me and said, I just learned of an experimental fertility preservation procedure called ovarian tissue cryopreservation. I found information on it at a local fertility clinic. So far, I have found a couple of children's hospitals that do it, but not drivable. Please let us know if this is possible at Seattle Children's. I include this email from a patient family is that this is really important to our families, and particularly at this time, with the pandemic, being able to travel for these services may not be possible, especially with patients who have many other comorbidities like low counts or have really time-sensitive medical issues. And so families are willing to travel and to go anywhere to help preserve their fertility of their children. And patients as well are willing to travel. And so we just say that to recognize that this is really important for us to really offer the full comprehensive services here at Seattle Children's. The second is a little bit different email. This is a patient who has now already gone cancer therapy and is now meeting with a follow-up provider. And the email said the patient was very sad that her ovaries are no longer functional and that she would not be able to use her eggs in the future for IVF with a gestational carrier. I think that she is just now coming to terms with that reality and appropriately grieving. Her mother felt guilty that she did not advocate for her fertility preservation earlier. So this is really highlighting how impactful this is to our patients who might have undergone cancer therapy as a child or as an adolescent, and how this really can impact their coping and grieving process well into survivorship. And this email was shared with me by one of our pediatric and adolescent gynecologists. So we know that this is important, and when we talk about the oncofertility movement, or really the movement of fertility preservation in cancer patients, it's really a pretty young movement. So if we kind of look at this at a timeline, the first time in which we started to see actual national committees and councils work on this was only in 2004. So ASRM stands for the American Society for Reproductive Medicine, really formed its first interest group at that time, in addition to the President's Cancer Panel, put out a report on survivorship and recognized infertility as one of the top concerns. There's been other NIH institutes that have put in research sections back in 2005. The very first guidelines regarding fertility preservations were put out for ASCO, or the American Society of Clinical Oncology, in 2006. We move forward, it really wasn't until 2012 that egg freezing was deemed non-experimental. This is different than what you might be familiar with something called embryo freezing or a fertilized egg. And then finally, what is really exciting, and some of the things that we'll be talking about today, is in 2019, a method called ovarian tissue cryopreservation was deemed no longer experimental by the American Society of Reproductive Medicine. And so it's this kind of growth and rapid growth in this area that spurred the program and the services that we want to talk to everyone here today.
So I'm just going to take a minute just to back up to the beginning a little bit and just talk about what we know just about the normal functioning of female and male reproductive system. And this just helps us because we put all of these options that we have for people based on some of the normal functioning, because that's what we're trying to get back to. So for females, obviously the ovary and the gonadal tissue, I think in both males and females, I want to point out too that there's the part about reproduction, and then there's also the part about hormonal function. And sometimes we look at those together, and sometimes we look at those apart. That they go together a little bit more for females than they do for males, but I'm going to talk about them a little bit separately now. And sometimes the Treatment is part of the problem, and sometimes the cancer itself can be part of the problem as well when we're talking about cancer therapy. So females, I think it's important to remember that females are born with a lifetime of oocytes. At birth, the ovary will hold about 1 to 2 million oocytes. And just as a natural process of life, going forward as a female hits puberty, that number drops just by itself to about 400,000. And of those 400,000, only about 400 of those mature. And so one of the things that we'll be talking about later on in our talk is just about the decline of how many oocytes are in the body as well as a result of treatment. And so knowing that that happens somewhat naturally and is accelerated in the future, I think is important to know as well. The hormone production, the ovary produces both progesterone and estrogen, and those are responsible, of course, for female traits, characteristics, their body shape, hair, ovulation, pregnancy, and fertility, and are regulated by the rest of the body and the pituitary gland as well. For males, there's both also, again, reproduction and hormone function. Sperm production, unlike oocyte production, though, is ongoing. The male testes is producing about 1,000 sperm per second, and that full regeneration of the sperm cycle goes over about 64 days, or about 2.5 to 3 months. And that becomes important when we're talking about when can a patient with treatment or cancer do some sperm banking. So 2.5 or 3 months, that there's a full sperm regeneration cycle. Of course, the main hormone produced is testosterone. And most often, actually, that is not affected by many of our cancer treatments. Some things like radiation affect that more often. But unlike females, the hormone function in males tends to remain intact for longer. Next slide, we'll talk about some ovarian anatomy.
Right. So like we said, to really be able to understand this talk, we really want to go back to the basics because I think it really makes it easier to comprehend. So I want to talk about ovarian anatomy. What I have here is a picture of an ovary that's been removed from the body. We typically meet with patients and say that an adult ovary is about the size of a good-sized grape. And so when I describe this to patients, all of the eggs within the ovary itself are contained in the outer cortex, or the skin on the grape. And then there's the middle part of the grape that supports it, which is the medullary cortex. So what you can see here in these pictures, in the middle picture is the part where the outer cortex has been totally removed from the ovary, and then there's that middle medullary aspect as well. And then when you look on the far picture on the right, you can see there, that's what it looks like under the microscope with H&E stain. And you can see the different follicles which are developing in a mature oocyte. So now let's talk about what happens in a normal state and then what happens after cancer-directed therapy. So the chart on the left is on the y-axis is the number of eggs contained within the ovary or the oocytes in a logarithmic scale. And you can see patients are born with the most eggs they'll ever have at birth. And this number kind of naturally decreases with time and age. So you can see menopause occurs when the total number primordial follicle population drops below a certain threshold. And so the average age in the United States is somewhere around 50, but the natural standard deviation can occur as low as about 42 to 43 and upwards to about 60. And so what happens normally under basal conditions is patients have eggs that grow and undergo folliculogenesis and continue to mature into a dominant follicle. When we talk about the impact of cancer therapy is when we use radiation or chemotherapy or other ways to treat cancer, we can do a lot of chemotherapy-induced ovarian damage. So this can lead to atresia of those primordial follicles. It can lead to inflammation and vascular damage within the ovary itself, and it can cause degradation of the ovaries of the current eggs that are near maturation. And so what this does is can dramatically reduce the ovarian reserve and cause a significant loss of follicles and can really bring that fertility window, if it at all remains, to somewhere in the age of menopause closer to like 20. But we know that not all cancer therapy is created equal. And so one of the things that can be challenging is how to predict what might happen after receiving certain chemotherapeutic agents. And so we know that with cancer treatment, there can be some low toxicity and really minimal impact on the ovary, and patients kind of mirror what is normal age decline of ovarian reserve or oocyte number. We can have patients who have moderate toxicity where it does actually decrease that window where an individual could choose to start a family. And that can be pretty dramatic, or it can be very minimal. So it can reduce it by 10, 15 years, or it can only reduce it by, 5 or a couple years. We also have really toxic medications, which essentially wipe out the entire egg pool or the oocyte number and really makes patients infertile right at that exact time. So there's it's really can be difficult to determine premature ovarian insufficiency, but there are some tools that we can use to help guide us clinically to know if a patient still has retained fertility or if they're at risk for premature ovarian insufficiency. Some of those tests that we could use is something called an AMH or an anti-Müllerian hormone. So in the normal state, this is an elevated number that represents the number of eggs that are in reserve or still within the ovary. You can also have kind of normal stimulation of LH or luteinizing hormone or FSH, follicular stimulating hormone, in the pituitary gland to the ovary. What happens when there's a decrease in the number of eggs within the ovary is that AMH number drops off. It gets quite a bit low, and you can see a pretty substantial decline. The pituitary senses the lower amount of eggs and hormones being produced, and so it actually tries to upregulate FSH. So you can see a high surge in the FSH with or without a change in the LH number. So now that we've kind of gone over ovarian anatomy, structure, function, and really stimulation, now I'm going to pivot to our male patients and talk about spermatogenesis. So unlike female patients who are born with all of their eggs at birth, our male patients actually develop this whenever they go through puberty. And so this is a enlarged picture of a testicle, and within the testicle, you can see that there's these red squiggly lines are the seminiferous tubules. Within these tubules, this kind of naturally mature from the outside towards the inner lumen. So you go from the spermatogonia stem cells all the way up out to the middle, which is mature sperm. And this is not present until a young patient goes through maturity, sexual maturity. And so this is really one of the important things that I want to impress upon really anyone that's listening that provides care for patients who might be receiving gonadotoxic therapy is that one of the first things you need to determine for male patients who may be eligible for fertility preservation is to determine their sexual maturity. One of the best ways to do this is using the male Tanner staging system. It's not perfect, but it's really can be helpful. And so for patients who are really eligible to undergo sperm banking, they really need to at least be Tanner stage 3. So usually this includes some pubic hair development, but really one of the better markers is the total volume of the testicle. And so there's orchiometer beads that many of us don't carry around, but it's at least a volume of about 10 milliliters per testicle. And this average age where we can see this is about an 11 and a half to 13. But it can be even older or sometimes even younger. And so that's why really doing an exam on a patient is necessary. But being sexually mature is not the only aspect that you really need to know because there's other more mental and emotional aspects, which we'll talk about later. So that's really a review of the ovarian anatomy and oogenesis. And now we're going to pivot and we're going to talk about tools that we can use to risk quantify or quantify the risk for gonadal failure and infertility. And so just to take a step back, so what are we risk stratifying in fertility preservation? And we're talking about the risk for infertility from disease-directed treatment. But there's a caveat to that, which is this is prior to the opportunity for an individual to reproduce to their desired intent, not the represented intent. So just saying, oh, this patient already has a child, fertility may not be important to them. That's not what we're talking about. We're talking about the individual patient's desire to produce a family. So let's get started. What are the things that really cause problems as it relates to fertility? Well, the first is radiation. It's well documented in the literature that radiation to different sites, including the ovaries, the testes, or the pituitary gland in itself, can really cause a problem with fertility. The next thing is some of our chemotherapeutic agents, and the ones that we really think about first are alkylating agents. So these commonly go by the names of cyclophosphamide, ifosfamide, melphalan, which is commonly used in bone marrow transplant conditioning regimens. These things are particularly toxic to the ovaries and the testicles. And they're not all created equal. And so we have to actually really determine the risk of each of these agents when determining how likely is a patient to retain or lose their fertility. And the final thing that we prescribe a fair amount, particularly in solid tumors, are heavy metals. So for us, that's cisplatin and carboplatin. These medications are particularly toxic for male patients and spermatogenesis, and so it has been included in the risk stratification system. So as I mentioned before, not all of these alkylating agents are created equal. And so what we try to do as the fertility team here at Children's is help different providers understand the individual risk for a patient. And so we look at when we meet with a patient or consult with providers, we want to understand the full treatment plan that's going to be proposed so that we can take the different agents and get what is called a cyclophosphamide equivalent dose, which will be then used to help guide our recommendations moving forward. And so a lot of the risk stratification that we share with patients has really come out of amazing collaboration from the Oncofertility Consortium, which Kristen and I are both members of. And the Oncofertility Consortium was really started under the amazing leadership of Dr. Teresa Woodruff, who originally started this at Northwestern and has now transitioned over to Michigan State. And so it's out of this group and through collaboration that really in 2020, we were able to get our first oncofertility risk stratification system for pediatrics, adolescent, and young adult patients. And while it's not perfect, it's really a starting point for us really to have a common language to talk about what is the risk patients are going to experience. So this paper was published with the lead author of Lillian Meacham in 2020 is really a lot of the foundation for the work that many people across the country are using to guide decision making and also talk about risk with patients. So I'm going to start here with our female patients or patients assigned female at birth. So what this paper has done is placed patients into 3 different risk groups: minimally increased risk, significantly increased risk, and a high level of increased risk. There was a lot of discussion about what the names of these groups would be, and so this was ultimately what was decided. So if you have questions about that, we can talk at another time. So what we're able to do is look at the different exposures, so alkylating agents, heavy metals, transplant, and radiation exposures, both to the ovary or the brain and the hypothalamus, and then take that and extrapolate out to what is a risk category patients fall into. And so as you can see, for female patients, the alkylating exposure is divided by pubertal status. So with patients who have not undergone menarche or their first menstrual cycle, being able to tolerate more cyclophosphamide exposure. And so the thought process there is that the oocytes or the eggs are very dormant and therefore not as vulnerable to the exposure to cyclophosphamide or other alkylating agents, and so they can tolerate more. Whereas patients who are undergoing regular menstrual cycles are having more active tissue that is going to be more sensitive and vulnerable to these different medications. For male patients, it's actually interesting because there isn't really a difference based on age. And in fact, if you compare the two, male patients can tolerate quite a bit less of alkylating exposure, and it's more binary. So anything less than 4, we say patients have minimally increased risk. If you have anything more than 4, that's a high level of increased risk, in addition to adding in cisplatin, carboplatin, and radiation. So the number one question that we get with these risk stratification systems is, well, what does that mean? What's the number? What's the percentage? And to be honest, we don't have a great exact number, but what we generally tell patients based on the literature that exists is that if you are in a minimally increased risk group, there's greater than an 80% chance that you will likely maintain your fertility after the completion of therapy. How long will that fertility remain, or how long will you be able to start a family at your choosing? That's a different question, but completion of therapy that you would have some fertility left is greater than 80%. And that's about as much as we can really provide a number. And then from there, it's kind of a greater discussion about how much does this risk grow up with as these numbers go higher. So now we've reviewed anatomy and risk stratification, and now Kristen's going to talk about what are the things that we can do to actually preserve fertility for our patients.
This is really, I think, of what my job is as well in terms of seeing patients, is going through this exact process that we're going through with you, is to teach patients about their own anatomy first, because that to that level of detail, as patients don't always know it. And then the second thing that we do for patients is to establish their risk and explain to them exactly what we did for you, of explaining the risk-based strategy. And then this is the third part of what our fertility preservation consult looks like, is explaining to patients what their options are based on their risk status. So I'm going to go through all of the options with you, and then we'll go back around again to that risk-based chart once you've heard these options, and show you how these options fit in when we're looking at it from a risk-based profile. So the first thing I'm going to talk about is oocyte preservation, which has been around a little bit longer than the whole ovary cryopreservation. And this is a process in which a female's oocytes are stimulated, extracted, and stored to preserve their fertility. There was a first human birth from this type of procedure in 1986, and it was determined to be no longer experimental to freeze just a plain oocyte, not a fertilized oocyte or an embryo. That was in about 2012. It's now considered actually the preferred way to preserve fertility for a post-pubertal female. So the way it works on our end is if we determine that a patient, based on their pubertal status and time to chemotherapy, is eligible, and I'll just make a note about that. It does take some time to have this happen. So I think we're down to about 2 weeks now, but somewhere between 2 and 3 weeks to refer a patient to the reproductive endocrinologist, have them go through the stimulation process and the extraction process prior to starting any chemotherapy. So you can imagine with some of the patients that come to us really, really sick, this just isn't an option for them because they don't have 3 weeks, 2 or 3 weeks of time to wait to start their chemotherapy. So that's one of the things in the risk calculator that we're thinking about. The second thing that they do, so the reproductive endocrinologist then will do an assessment of their ovarian function by both doing labs and with a pelvic ultrasound. And our partners in reproductive endocrinology for some of our younger patients can do some of these either abdominal ultrasounds rather than doing a transvaginal ultrasound, which is, you can imagine, for a young teen, could be a little bit traumatic. They do have the option to do some of the parts of these procedures sedated, but I think not the ultrasound part, they do that really as an abdominal ultrasound if they can possibly do that. Third part that comes is they stimulate the ovary with medications. There's a pretty complicated process for obtaining these medications. They're really quite expensive. There are some methods to help pay for those medications, and those are all prescribed by the reproductive endocrinologist. And the patients are getting those at home and then followed along by the reproductive endocrinology team. The nice thing is that you can do this as a random start. It doesn't matter where a patient is in their menstrual cycle, so they can start this at any point. So that doesn't extend that 2 to 3 week period any longer based on the menstrual cycle. Following the ovarian stimulation, the patient's oocytes are surgically removed. And this part is actually done under sedation, and we nicely have the ability to be able to do that through our endocrinology partners. This currently remains the best option, second to a fertilized embryo. The best option to produce a live birth after that, and that's steadily improving pregnancy rates. Currently, somewhere between 38 and 55%. The cost for this is it can be a barrier. It's a fairly expensive procedure, but as we go forward, we are really finding a lot of philanthropic partners to help us with this and to help out with our endocrinology partners to be able to do this. That's actually really, really exciting that there's getting to be some help for this. The average cost just for the procedure is around $6,000 to $8,000. It can be more, and it's definitely more at different places around the country. And it changes with how expensive the medications are and what philanthropic partners are available to be able to produce the medications. That's just for the procedure itself. The eggs then also need to be stored, and there's an annual storage fee, around $300 to store the eggs. And again, there's some programs that patients can use both for cancer-directed diagnoses and for non-cancer diagnoses to store some of these eggs. And whether or not insurance pays for that is really plus or minus. Tyler will talk a little bit more in the later in the talk about sort of what's happening with insurance, but that can really be hit or miss about whether or not patients have these provided for. One question, or one just to mention about some of the procedural risks that happen with this. It's actually fairly well tolerated, but there is some concern for ovarian hyperstimulation. It doesn't happen very often, but it's where the ovary is so stimulated and so enlarged, there gets to be a lot of fluid accumulated in the pelvis. And you can't start chemotherapy if that happens. But the reproductive endocrinologists really help us to be able to manage that. And again, we've had it happen before, but it certainly does not happen very often. It's actually fairly rare. Infection and bleeding is another one, but these patients are generally sent before they are doing any kind of cancer treatment. So that doesn't tend to be as much of an issue as for somebody who is on treatment. And this is actually something that we can offer to a patient in any risk category. So that's nice as well. So this is the statement that Dr. Kettle was talking about the ASRM statement, that we now have the ability to preserve really the whole entire ovary. So this became important because there was no option prior to this time for patients who had not gone through menarche yet. And so this was to be able to preserve the entire ovary by taking out entire ovary and freeze that as a whole became possible in 2019. The ovarian tissue banking, we now know, is an acceptable fertility preservation technique and is not experimental. The use of the oocytes to produce fertility at a later time, they're still working on their techniques of that, but the actual freezing of the tissue itself is no longer experimental and can be viable in the future. So let's dive into a little bit more about what this ovarian tissue cryopreservation looked at. The recommended technique for the ovarian tissue cryopreservation is a laparoscopic unilateral oophorectomy. We generally reserve this for patients in the highest risk category for the reason I just mentioned, in terms of because it is a surgical procedure, and also because the use of the tissue at a later time, we're still working on the technology for that. So it doesn't really make sense to take out someone's whole ovary in the minimally increased risk category for infertility, because we would be adding issues rather than solving all of them going forward. The technique of taking out the whole ovary is really important as we talk about younger females. The ovary actually grows in size as the patient grows. So that little ovary in a toddler is really about the size of a jelly bean. And so taking out the entire ovary becomes a lot easier as we are breaking it in half and then putting it into strips. Using that whole ovary actually helps to preserve many more of the follicles that are important to use in the future. This procedure is done generally laparoscopically, like I said. However, there is an open procedure for a patient who's getting their surgical resection. That's another time that we can offer this procedure as well. For example, a neuroblastoma patient, we've done some of those where the patient is already having an open abdominal procedure, and then this part of that is added on, and is very quick. So they remove the ovary. You can see a picture there on the left where they're grabbing the ovary and then cutting it from its blood supply, and then suturing that up there at the site inside. They put it in a dish on the side and cut it in half. And that then gets sent we package that up into a shipping container and send that off to the University of Pittsburgh Medical Center. and they do the part where they cut it into strips and then slowly cryopreserve it there. And from that point, then it gets shipped to a storage facility. Currently, ours is in Minnesota right now. And all of that whole procedure for the processing and sending it to the storage is about $1,500 now. And that number, I think, probably $1,600 now as we're adjusting that. But we hope to do, and we're working all the time about ways that we can minimize those costs to patients, either through philanthropic assistance or through developing centers that are closer to us, so where we can help to adjust some of those costs. So we know that these are big costs to families, and we wanted to be doing everything we can. So part of our job in developing our program here is developing partners that will help us and help our patients, as well as making the procedure itself safer and easier for more people to access. One of the advantages of this procedure is the time frame. Really, we only need a couple of days to get it done. I think probably about a week is what we need to organize it from the time that we know a patient needs the procedure, to be able to get the surgeon in place, to be able to get the storage facility ready for the procedure and talk to the family about the procedure. Really takes about a week. The actual act itself really happens all in the day. It's just the coordination piece that takes a little bit longer. And I think exciting, and we'll talk a little bit more detail coming up about the success rate. I think that has become much more successful just in terms of being able to produce a live birth. That data is mostly from post-pubertal ovaries, but we do have data from pre-pubertal ovaries that are stored that now we can produce some live births through assisted technology as well, which is really exciting and makes this a much more viable options for family, and is part of why it is not as experimental. I talked about the cost. There's also the same storage fee like we were talking about with the oocytes. And the risks to this procedure are really mostly procedural, just the risk of bleeding, the risk of infection, and why for patients we require that patients are old enough, over the age of 1, so that the ovary is big enough so that we can get it. Patients that have leukemia, also we need them to be MRD negative, so no evidence of cancer in their system when we take that out. Like this would be like for an example of a patient who was on their way to transplant but had a leukemia diagnosis. It would be important for them to be MRD negative so that we weren't transplanting any cancer back into their body at another point. And also, just because it is a surgical procedure, making sure that that patient has adequate blood counts so that we are not adding to their risk of any type of infection doing that. Let's talk a little bit about how that ovarian tissue can be used in the future. In the top picture up there, you can see that we can take that ovary that has been frozen and thawed, and you can transplant that ovary, which is really cool, back onto the other ovary that may still remain. So remember, we talked about doing this as a unilateral procedure. There's still an ovary left in the body. When you're transplanting it back to the ovary, this is after their cancer diagnosis is done. This is when they want to try to restore either hormone production or fertility. You can see the strips that they put into that little petri dish and froze. Those are quilted then onto the existing ovary. That's in the center picture here up on the top. They're put back onto the existing ovary on the other side and then covered over with this mesh to hold it all in there. So that would be if you wanted to put that cryopreserved ovary onto maybe what's a poorly functioning ovary left in the body, that the plumbing still works on that existing ovary, but the follicles inside that existing ovary may not be working well. And so here's how you can put some follicles back in. And then those eggs can find their way through the existing into the uterus to be able to be fertilized. This transplantation into a peritoneal pocket is something that they've done that before, where even some of the follicles can find their way to the uterus even that way as well. And the transplantation can even be to put into somebody's arm to just even restore hormone function. So they're really working and using a lot of methods to try to determine how to put these ovaries back into people to be able to restore both hormone function and fertility. It's pretty exciting. I mean, I think every week we get lecture talks about people that have learned another thing to do. So I feel really confident that, especially these little people that we're taking these ovaries out of, when they come to use them 20 years from now, we're going to know a lot more about how to use these to their advantage at that time. So again, these are the ways that we talked about using the tissue. The auto-transplantation, where those were the pictures that I had shown you before, the different places that you can put at it. So, when we talk about taking out the pre-pubertal ovary, you have these primordial follicles that are not yet matured. You can put them back into somebody. So you can take somebody's ovary and put it back onto the other ovary and have that function. But being able to mature those primordial follicles outside of the body and put them back in somebody, that part is still experimental. But you can see here on the right-hand side in the graph, this is the how many live births, and actually this is kind of old data. I think there's probably some newer data out there that we can that we're hoping to get, because it increases, I think, every year. But you can see how quickly the number of live births from this procedure has been increasing, even in the really recent past. And then Dr. Ketterall here, I'll talk to you about some of these specific examples that are really exciting.
Yeah, so these cases are really, I think, what excite us. So I'm going to run you through two different cases. The first is a patient with a non-malignant disease, which is sickle cell anemia. So in this case report that was published in 2015, they had a patient who was diagnosed with sickle cell disease at the age of 5 and underwent pubertal changes at the age of 10. So, but then underwent a transplant and ovarian tissue cryopreservation at the age of 14. But although the patient had pubertal changes, had not previously started having menarche. And so after the patient underwent and recovered from bone marrow transplant, menarche was induced through hormonal supplementation. What's exciting is at the age of 25 years, the patient had confirmed premature ovarian insufficiency, and that was confirmed prior to transplant and then after transplant. And what was at that point in time, sorry, I misspoke there. The patient had premature ovarian insufficiency prior to transplant of the ovarian tissue back into her body, or the ovarian transplant. So the ovarian tissue was transplanted into the residual ovary, as well as placed in a peritoneal bursa and subcutaneous tissue. And what was really exciting is that this case demonstrated that this patient was able to restore her FSH and her LH to pre-menopausal range. She started to have regular periods. There were follicles that were seen on ultrasound from that tissue, and her AMH was detectable, or she had a change in her AMH after the reimplantation of the tissue. So this really highlights for us that we can use tissue to restore endocrine function and kind of reset the hypogonadal axis. The most recent case that was published in just last year is something that we're excited about in the oncology community. So this is a patient who was diagnosed back in 2001 with acute lymphoblastic leukemia. The patient was diagnosed at 14 years of age, had high-risk disease, and ultimately went on to receive a hematopoietic cell transplant with total body irradiation, which is associated with that very high risk. And the patient did have ovarian tissue cryopreservation prior to chemotherapy, or post receiving some chemotherapy, but prior to getting her transplant. So when she was that MRD negative, which Kristen referred to before. She did have documented permanent ovarian failure by lab tests and by ultrasound. And so the patient ultimately underwent 2 auto transplants of her ovarian tissue. The first was at age 29. And so with this, the patient was actually able to have 2 births. One birth was through IVF, and this occurred in 2019, and had a healthy baby boy at 35 weeks. And then at the time of the publication, the patient had a second pregnancy that was conceived through natural conception, so without the assistance of assisted reproduction. And at the time of the paper being published, the patient was 35 weeks gestation. So it's really exciting for us as we think about using this tissue that we've cryopreserved, and that we can actually help families build families in the help patients build families in the future. So as we think about fertility preservation options, as we mentioned before, we're really taking these risk factors and risk stratification, age, pubertal status, and all of these factors together to make our recommendations for what we should do when and for which patient populations. And so, as Kristen mentioned before, we're really reserving ovarian tissue cryopreservation in prepubertal females currently for those who are receiving that very high risk category. And really that recommendation comes from the sort of lack of confirmation data that we can actually have live births. And hopefully this might extend to the significantly increased risk group in the future as well. For pubertal patients, it's a little bit different. As we mentioned before, our kind of preferred method, if possible, meaning that there's the right amount of time and ability to do this, we would prefer to freeze oocytes or the eggs. And that can really be offered to any patient, minimally increased risk, significantly increased risk, or high increased risk. But many times there's patients who can't undergo this right away at diagnosis. They either need to get started with therapy, or they cannot tolerate stimulation, or can't wait for that kind of 2 to 3 weeks to start their cancer-directed therapy. So some patients, we can do this after chemotherapy, but what we think about is for our leukemia patients, we want them to be in that significant or highly increased risk group and be MRD negative, and hopefully have recovering of their counts that makes them safe for the procedure. And similar things for our patients who have a solid tumor, a CNS tumor. There's not that consideration of MRD negativity, but we can also try and couple this with other procedures such as line placement or a surgical resection.
So we talked a little bit about how we think about that prior to a cancer diagnosis or even in the middle of a cancer diagnosis. But I also want people to keep in mind still continuing to think about fertility preservation after chemotherapy. And I've been doing this a long time, and I have a lot of patients who didn't have these as options when I first treated them, and now they're being seen in off therapy or in survivorship. And so some of these options can still remain really great opportunities for them, even and especially even in the off therapy period, now that we have the technology to do it when they don't have a current cancer diagnosis. But if you remember how your fertility can drop off as you go over time, that these can be available to them. So both oocyte cryopreservation and ovarian tissue cryopreservation can help to then decrease that window. Okay, let's talk a little bit about male fertility preservation. When we go into talking about male infertility risk, some of the principles I want you to remember is some of these long-term outcomes are really, is this patient fertile or not fertile? Whereas, remember the amount of follicles that a female has, that can be really variable. So you might have a long time to use your fertility, you might not have a long time. Males either had their sperm available to them or not. It was either, it's a little bit of less of a complicated discussion, a little bit. The risk to infertility does not vary greatly with age, unless you're talking prepubertal to postpubertal as well. But the risk to the testes doesn't change very much by their age and the doses that they're getting. We do know that males do have a period of temporary azoospermia when they're getting, like the postpubertal male does have this azoospermia following and during treatment, sometimes even at the beginning. And sometimes we don't know how long that's going to be. So some patients recover their sperm very quickly, and others take a little bit longer to do that. So sperm cryopreservation is our preferred method for males because it's non-invasive. Like Dr. Kettle said, patient must be a Tanner 3. I think that's pretty variable. You can do that by physical exam. I think there's a lot to know. Also by a really skilled interview with a patient as well. Patients must have masturbated previously and really know what that is. I've learned just in these interviews with patients that this can't be something that parent teaches the child the day before and then they go try it out. I've gotten to know pretty clearly who understands what that means pretty right on, and other people give you that kind of look that they don't really know. They're not quite ready for that. We talk to them about prior to providing their samples, they can't use any assistants like lubricants or saliva. It dilutes the specimen. We give them that information, as well as the group that's receiving their sperm also does that as well. It's also important to know that because sperm are constantly exposed to the chemotherapy, that any sperm collection needs to be done prior to chemotherapy starting. Another way to get sperm, before I talk about this, because it's a little bit different, is not just with masturbation, but there are some patients that we do have our urologist do take a little sample of their testicular tissue. This is in the post-pubertal male that has mature tissue, but maybe can't masturbate or ejaculate because they have a spinal tumor with some neuromuscular, and they can't have ejaculation. So those patients, they can get that. This particular procedure that we're talking about, this testicular tissue cryopreservation, is for pre-pubertal males, and that is only offered by an experimental protocol that we will have open here at Seattle Children's very soon. So this will be offered to pre-pubertal boys who are going to be exposed to high-risk treatment. And again, that will be like a surgical removal of part of the testicular tissue and then frozen down. And what the part of the experiment is in this is how do we freeze this tissue down so that it can be used later on. Because of the extreme toxicity of a lot of different kinds of chemotherapy, we really want people to think about sperm cryopreservation for all males, and that it's strongly recommended that sperm be collected before the initiation of treatment, because we don't actually know what will happen to those patients afterwards. We hope that they will be cured and that they would have normal fertility later on. But even patients that have minimal risk to their chemotherapy, we offer them the ability to be able to cryopreserve their sperm, because it gets even harder after chemotherapy has been given, and sometimes patients take up to a year or more to recover their ability to make sperm. But we don't need very much sperm to be able to fertilize an egg. So just having a few sperm, even if they want to just try, if it's been long enough after the exposure to chemotherapy, we would like for them to be able to do that.
All right, so we're going to bring this to the home stretch now and tell you about what is the comprehensive fertility preservation program that we have at Seattle Children's and what can we offer to our patients. And thankfully, I think we're able to say that we can offer the full comprehensive services to all of our patients, including a comprehensive evaluation that includes risk stratification, options available to them, and then counseling for survivorship care as well. And this is really a huge partnership with the oncology team, general surgery, urology, adolescent gynecology, and our colleagues in reproductive endocrinology at University of Washington and Seattle Reproductive Medicine.
We have individuals in all of those fields that have been our champions in this, and our program would not work without them.
Yeah. So what we have here is to kind of review, for our pre-pubertal patient, the only real option that we have at this point is ovarian tissue cryopreservation. For the pubertal patients, we can also offer ovarian tissue cryopreservation, as well as oocyte or embryo cryopreservation. And that's with an outside referral, which allows us to get our patients in very quickly within sometimes less than 12 to 24 hours. For our male patients, we're able to do testicular tissue cryopreservation soon. We have an IRB approved protocol here at Seattle Children's, and we're just going through the final parts of implementing this protocol. Again, this will be experimental, and we share with every patient that there have been no live births to date as part of this method, but we're hopeful as the tissue matures and when patients might be ready to use it, that there will be a technology that allows them to start a family. For our pubertal patients, again, we have sperm cryopreservation as well as testicular sperm extraction, which is the method that Kristen talked about before, where we take a small piece of the testicle out and essentially get the sperm out of the tubules. We will be able to offer testicular tissue cryopreservation to patients who are pubertal and for whatever reason wouldn't have been able to cryopreserve sperm or testicular sperm extraction, but we're hopeful that will be a fairly small subset of patients and that they will have been able to do these other methods first. And so finally, where are we at for this to get insurance coverage and to be able to equitably offer this to all patients within our state and in addition to the WWAMI region and across the country? Well, currently there's only about 11 states that have insurance or fertility preservation coverage where it's mandated by the insurer. Washington is unfortunately not one of those states. So there's a group of us who have formed a Building Families Coalition who have worked to write legislation that will mandate this to be covered by our insurers. And this is really a comprehensive fertility preservation bill that allows for patients to do fertility preservation and then be able to use that tissue in the future, and really treats infertility as an illness, which it's not something that's just a luxury to be able to start a family. So this bill has been reviewed, underwent a sunrise review by the Washington State Department of Health. It then was, the bill was reviewed by the Washington State Medical Association and has thankfully been favorably reviewed and recommended for passing, and has the full support of the Washington State Medical Association. And we now have two bills that have been introduced to the House and Senate with sponsors, and their bills HB 1730 and SB 5647. This bill is currently undergoing now another review by the Insurance Commission, and has been marked by the governor's budget to be funded for full review. But I reach out to you, everyone that's listening, to say, if you can reach out to your representative and tell the story of why this is important to you, or why this is important to the patients that we care for at Children's, we would greatly appreciate it, because we would like to not have to deal with the absolute heartbreak of offering this to families who would only be able to pay. And thankfully, with our philanthropic partners, we don't have to do that much, but it still can be a significant impact on families. So this is kind of the conclusion of our talk. Hopefully you can been shown what our new female fertility preservation methods, such as ovarian tissue cryopreservation. We've talked about male fertility preservations that are limited and that they should be offered prior to gonadotoxic chemotherapy. Hopefully you got a little bit of an introduction to the risk stratification system that came out of the Oncofertility Consortium. We hope we've provided some clarity around the definitions of risk and implications of these risks, and how crucial it is to our patients, and how important it is for our patients' long-term coping. And finally, we want to finish by saying Kristen and I and our team are really hopeful to be a resource for everyone within Children's, and as well as our partners in the WWAMI region. You can reach out to us individually, or you can use our email address, fertilitypreservation@seattlechildrens.org, with any question. There's no dumb questions. This is a constantly changing field, and we hope to just be a resource for anyone. So that concludes our talk, and we just want to thank everyone for the opportunity to speak to you all today.
Thank you so much for that talk. Very, very interesting stuff. And I'm so glad that there's technology out there that's being worked on to help our patients. And so folks, if you have any questions for our speakers, please type in the chat. I do have one question, and it's regarding consent for these procedures. You know, I think the younger prepubertal patients, I'm assuming parents would be, you know, asking for these procedures, but in that age, you know, where patients could consent for certain procedures, how do you navigate that, and who initiates that conversation?
Yeah, that's a really great question. So for many of our patients, there's certain, we're used to talking about consent and assent. So for our patients who are less than 18, we really need to have consent from their parents. But for many of our patients who are really participating in their medical decision making, so really starting to think about probably 9, 10, 11, 12, we really want those patients to also provide their assent. On our forms, we do have a minimum age requirement, there's an age requirement for which assent is absolutely mandatory. And so that's really, I believe it's at 12, in which we need to have assent, but our patients and their families who are less than 18 really need consent from their parents.
There's also some different rules in the storage facilities as well. And that's a separate contract that families have with a storage facility about the use of the gametes and later use. And most places, I think, now have it so that it is really only the patient that can direct the use of those gametes, as opposed to parents being able to do that.
Interesting. And is this something that you would routinely ask or offer patients?
All patients?
Yeah, patients who would, undergo procedures that may impact their fertility.
I think it's our hope that every patient that comes through the doors at Seattle Children's who's receiving any therapy that impacts fertility has a discussion and a real formal, educated consultation about fertility preservation. Again, that's a lot of patients that actually receive these types of therapies here. And so we're hopeful that we can build our team up and the knowledge within our institution about the impact of their therapy on their fertility, that everyone has an education and has the right recommendation for options to preserve fertility.
Mm-hmm. Yeah, I think that would be great.
What we're learning is that there's a right time for some of these conversations for them to occur. It doesn't necessarily always be for every patient to happen right up front before the therapy. We're kind of learning that for some patients with leukemia, really after that first month of leukemia treatment, where we're deciding on the next steps, that actually might be a better time to talk about fertility preservation measures, because it really guides our decision making. And it also, there's so much information overload up front and really a need to get going that we're finding that within certain patient populations that we deal with, there's a right time to talk about these things.
And we're branching out into our other departments as well, such as rheumatology and adolescent medicine as well, so that they know who we are, and working on methods to educate their providers as well, so that they know when to contact us as well, so that patients in other departments besides just oncology can benefit from these services as we grow.
Mm-hmm. And then my last question is, to retrieve the oocytes, you'd have to undergo, I guess, some sort of hormone therapy. I think that's what you mentioned. Does that procedure increase the patient's risk of ovarian cancer later on in life?
My understanding is that there is no increased risk of ovarian cancer from these procedures. We do know that just like the risk of ovarian cancer actually does come from the total duration of time in which someone is ovulating. And that really comes from the disruption of the cell lining on the ovary itself. So patients who have a longer ovarian window, a fertility window, actually have a little bit slightly higher risk of ovarian cancer.
Mm-hmm.
But whether or not there's an increased risk of cancer from just undergoing stimulation, I'm not aware of any data that supports that.
Okay. Well, excellent talk. Thank you for speaking to us today. And everyone who's still on the call, just wait for an email from us for your course evaluation. Thank you again.